Greetings, everyone. Thank you for joining us for the Robert Wood Johnson Foundation Systems for Action Research Program regularly occurring Research in Progress webinar series. For those of you who may be joining us new today, this is something that we do about twice a month. It's a chance for us to hear from research teams that are part of the Systems for Action research program at RWJF. This is a program that studies innovative ways of aligning medical, social, and public health systems, both helping us to build strong evidence around how to implement alignment strategies and understanding the impact of these alignment strategies on health and health equity. And as we typically do in these sessions, we have a research team that scheduled today to share with us work that they have been doing in studying an innovative system alignment strategy and sharing with us what they are learning about their specific alignment strategy and how it can help us to make progress toward the goals of health equity. I guess I should introduce myself. I'm Glenn Mays. I direct the Systems for Action Research Program for RWJF, and I'm based here at the University of Colorado in the Colorado School of Public Health. And our panelists for today are two colleagues from Columbia University, the Mailman School of Public Health. Both are professors in the Department of Health Policy and Management, Dr. Sarah Abiola and Dr. Miriam Laugeson, both colleagues who have a wealth of expertise in health policy and in understanding healthcare and public health systems. And in particular, their particular study funded through Systems for Action examines issues in strategies for aligning health and social systems, particularly using the terminology and coding and billing systems that we use in healthcare, and thinking about how to broaden those systems to better engage and support non-medical, social, and public health services. So we're really excited to hear about the work that has progressed under these two leaders, and I think our plan is to have the session be a little more interactive, maybe a little more interactive than usual, and try to get some insight from our audience members on some of these very important issues as well. So with that, I will turn it over to our panelists to kick us off.
Okay, great. Thank you so much, Glenn, for that warm welcome. It's wonderful to be here. Miriam and I are very excited to share what we've been working on for the past year, a little bit more than a year, and to really try to engage with the community that we think is rich with knowledge and expertise on this topic. So our format for today is going to be slightly different, as Glenn alluded to. We are going to start with a couple of polling questions for the audience, just to get you thinking about some of the things that we will eventually kind of touch upon as we go through our presentation today. We're going to spend some time at the outset really talking about our study aims and our primary findings. So we asked kind of three big questions, and we have different types of kind of conversations that we had with stakeholders that we really want to capture in some detail. So we'll both kind of talk through the history of T codes in particular, and some of the ways in which we've come to see them utilized and what we think about options for expansion. We'll wrap that together in a conclusion that really is less of a conclusion and more of a segue into next steps and emerging projects. So in many ways, due to the current pandemic, we found that there is just an opportunity to really push the conversation around integration in new directions. And we're going to share some of the work that we've been able to do in that regard as well. We're going to have a Q&A that hopefully will give everyone who has thought of different things or who was sparked by the polling questions an opportunity to engage with us in a more extended format. We can see all forms of question submission, so whether you put it in the chat or whether you send it through Q&A or even sometimes, you know, I don't know if this is a raise hand function, but I know that my students sometimes like to raise hands. Whatever works for you, we'll find it. And hopefully we'll have a chance at the end to do any program announcements that are outstanding. So I'm going to just kind of move right along into the kind of next set of slides, which are our polling questions. So in your opinion, we wanted to know, thinking across sectors, how much progress do you believe has been made to date on social and health services integration in the United States? And we'd like you to pick one of the following. And I believe that you will have a mechanism available to you to actually answer this question. And we'll give that kind of to you for a few moments. I've been told that the estimated time is like 8 seconds for people to answer these types of questions. So hopefully you'll have an opportunity to think about it and pick the option that works for you. Okay. And then we're going to move on to question 2. Do you believe the COVID-19 crisis has strengthened or weakened the likelihood of greater social and health services integration occurring in the United States? And again, pick one of the following. Not sure, no impact, reduced, somewhat strengthened, or significantly strengthened. And we're going to actually have a discussion about the poll results at the end of today's conversation. So you will see what we thought as a group collectively in about 30 minutes or so. So at this point, I'm going to actually turn it over to Miriam, and we're going to begin a conversation about our first study aim. And you'll forgive me if my screen is being a little bit wonky. I'm trying to move on to the next slide. There we go. All right, so study aim 1. Miriam, please, if you could talk to us about our findings for that.
Hi, welcome everybody. Thank you, Sarah, and thank you, Glenn, for the introduction. Thank you, Sardinia, for organizing this and putting all the technology together. It's really gratefully appreciated. In terms of our first aim was to understand the current state of play with regard to integration of health and social services. That actually required taking a really big step into thinking about 2 different things. The larger meaning of health, which I'll discuss in a moment, and health service, and the more practical question of how healthcare services are packaged and counted and measured. We did a deep dive into the humdrum but critical question around billing codes. Though often maligned, standardized billing and coding systems allow the US healthcare system to sort of work together across payers. And there's 5 billion claims a year, and these are processed in a reasonably ordered and consistent manner. This was no accident. This required a federal law, notably HIPAA, the Health Insurance Portability and Accountability Act of 1996, which requires the Secretary of Health and Human Services to select and establish uniform code sets for healthcare claims payment and distribute these code sets for widespread and consistent use by all payers, make modifications as necessary. And this legislation established the Healthcare Common Procedure Coding System, also referred to as HCPCS. So the HCPCS code set is an umbrella term for 2 different kinds of codes. Level 1 codes are known as Current Procedural Terminology, or CPT codes. These are a numeric coding system maintained by the American Medical Association to identify medical services provided by physicians and other healthcare professionals. So the AMA, the American Medical Association, makes decisions about the revision of CPT codes, and these are updated once a year. Now, level 2 codes are actually different, and they are alphanumeric codes followed by 4 numeric digits. The level 2 codes include medical devices, durable medical equipment, prosthetics, orthotics, and other supplies. So we've got 2 different coding systems, and notably, neither appear, at least, to include social services. And the next aim, we'll talk a bit more about that. So these code sets were created and maintained by CMS, and the HCPCS work group manages the level 2 codes. That group is comprised of a number of stakeholders, including commercial health insurers. The meetings are public, and they allow anyone to submit requests for coding changes. So this is a fairly technical and pretty comprehensive process that we have for establishing new codes. So the second big issue that we had to tackle was understanding what the nature of health services is and how that's defined. So in our research, we looked at this fundamental question, because bringing together health and social services requires different statutory approaches sort of being unified to some extent. And what we found was a great diversity of approaches in terms of legislative interpretations of what health services are. I can only touch on this in a couple of ways, and there have been long-standing efforts to expand the notion of health service using waivers through federal law. So state waivers provide flexibility to go beyond the traditional definition of health services. At the same time, each state has different ways of interpreting even something like community health worker. We looked at these community health workers in Minnesota and New York and Rhode Island. There's city differences and state differences. A diversity even with something like that. So at the federal level, beyond these waivers, there is a narrower scope of healthcare services. And originally, the Social Security Act actually defined it as medical care, i.e. benefits paid for the diagnosis, cure, mitigation, and I'll just skip over this language, any structure or function of the body. So it was a very medicalized term. Transportation, therefore, is a medical service only if it's related to receiving medical care. And to the extent that social services are mentioned, they're described as medical social services and only applicable in relation to an inpatient stay and prescribed by a physician. So what changed after HIPAA was a more expansive definition of health service. And at that point, they defined health service more comprehensively as related to the health of an individual. There was still, a lot of emphasis on sort of concrete services, but they also included, with respect to physical or mental condition or functional status, which really opens the door for consideration of social services. However, there's still a need for an interpretation that is consistent across federal programs. Now, I'm going to turn it over to Sarah. We're going to both discuss the aim too, but she's going to start off. So Sarah, please change the slide.
Sure. So thank you for that, Miriam. It's been a kind of odyssey coming to the point where we could actually start to have this conversation about T-codes in great detail. So we're going to talk a little bit about the history of T-codes and what they can and cannot do, and what we envision as the strategy to kind of expand their utilization. So as Miriam said just a moment ago, level 2 HCPCS codes, specifically T codes, which range in value from 1,000 all the way up to 5,999, already provide a framework for reimbursement. So these codes were introduced originally as temporary national codes for use by state Medicaid agencies, and many T codes could be used to address what we consider to be the social determinants of health. So for example, T codes have been developed for alcohol and substance abuse services, home health services, behavioral health services, non-emergency transportation, and family training and counseling for child development. Currently, T codes are used primarily by state Medicaid agencies for services or items that lack a permanent national code, and this is critical. We're going to come back to this idea of permanency. Temporary codes are created to meet specific operational needs of payers, and they do not have an established expiration date, so they don't sunset in any way. Private insurance programs can also use T codes, but these claims are not currently payable by Medicare. So we argue that expanding T codes and building a platform for additional services could address many of these social determinants of health that are currently excluded in many ways from the reimbursement scheme that's focused on kind of medical care and medical services in the traditional definition. This shift in utilization will require both statutory and regulatory changes. So in October of 2003, the Secretary of HHS delegated authority under HIPAA to CMS to maintain and distribute these HCPCS Level 2 codes. And CMS is going to continue to establish uniform definitions of services, codes to represent services, and payment modifiers to the codes. So ultimately, the first step in trying to achieve alignment, collaboration, and synergy, we argue, is for the HCPCS work group to decide to replace temporary T codes with permanent T codes so that these codes can be updated annually. So we need to make a shift from temporary to permanent. A significant advantage of transitioning temporary T codes into permanent T codes is that doing so would not require the CMS HCPCS working group to approve new codes. So as you might imagine, the process of creating new codes is one that can be fraught with all kinds of kind of controversy, and that is built into the system. So the goal is to have as many stakeholders contribute to the conversation as possible, but it also represents an opportunity for certain delays or holdups when it comes to thinking about moving forward with new types of coding schemes. So if we took codes that have already been adopted, T codes, and we shift them to a permanent code status, that would enhance both provider and payer awareness of a system of billing and reimbursement that already exists. So ultimately, the kind of startup costs are much lower if we use codes that already exist. The second kind of extension of this when it comes to integration is making T codes payable by Medicare. So as I just said, they're not payable by Medicare, but there is precedent for expanding the scope of services that are covered by Medicare. Medicare coverage was extended to cover telehealth services after HIPAA provided for a study of telehealth based on positive reports from various demonstration projects at the state level at the time. So the first telehealth codes in Medicare Part B coverage for telehealth services were authorized under the Balanced Budget Act of 1997 and expanded under Medicare, Medicaid, and State Children's Health Insurance Program, or SCHIP Benefits Improvement and Protection Act of 2000. So this is not something that's unheard of, and we have a relatively recent precedent for this type of expansion. Regulatory provisions were then enacted and supplemented, providing a more structured method of reimbursement for telehealth services under Section 442 of that Act. Given that the T codes already exist, we're arguing that this process could be much more straightforward, but would still require broadening the range of services covered by Medicare. So it's quite kind of obvious how we could make this transition. It would require statutory and regulatory action, but we avoid some costs by adopting T codes as the vehicle of getting to that point. So finally, I want to focus a little bit on aim number 3. And let's see if we can get there. Fantastic. And here we're going to talk a little bit about the ways in which we've seen this implemented already. So how have states moved in the direction of trying to really expand utilization of T codes in ways that speak to social and health services integration? And we find that they've attempted to do this through a mechanism that Miriam touched on earlier, which is waivers. So currently, state Medicaid agencies need a Section 1115 waiver to pay for T code services. So even though the T codes exist, even though they cover things that we consider to be relevant to the social determinants of health, a state must still apply for a waiver in order to use that particular form of payment. Section 1115 of the Social Security Act gives the HHS Secretary authority to approve experimental, pilot, or demonstration projects that give states additional flexibility to promote the objectives of Medicaid programs. While many states use Section 1115 waivers, as of September 2017, 33 states had at least one approved waiver, and 18 had one or more waivers pending approval by CMS. And I'll say, as a note to this, we've seen much greater utilization of waivers since the COVID pandemic. So it's a kind of mechanism that I think we're more familiar with as a result of the outbreak, and we'll talk a little bit about why that's both good and bad. I'll start with the bad first, is that they do present a statutory and administrative hurdle. So it is not the case that there's a precedent for just kind of automatic approval of state waivers. So even if there is a desire to engage in experimentation around increasing access to social services through T codes, there's no guarantee that it's going to be approved. What does have to be shown is that the waiver is going to increase and strengthen the overall coverage of low-income individuals, increase access to, stabilize, and strengthen providers and provider networks available to Medicaid and low-income populations, improve health outcomes for Medicaid and other low-income populations, and increase the efficiency and quality of care for Medicaid populations. So there's a premium that's placed on quality of care, efficiency, and outcomes when it comes to determination of Section 1115 waivers. And arguably, the services that are covered by T codes would be very relevant, would be kind of spot on in relation to addressing these needs of low-income populations. So ultimately, the kind of finding in relation to study A number 3 is that state Medicaid agencies should be able to use T codes without a waiver from CMS. So the best way to kind of implement and work around kind of barriers to promoting access to non-traditional, non-medical services would be to give greater access to T codes by eliminating the administrative hurdle of the waiver application process. So I'm going to stop here, and I think Miriam, you're going to provide a little bit of additional insight in relation to A number 3.
Right, and I'm going to touch on the issue of COVID-19, and I think this has provided a new opportunity for many people to think about the integration of social and health services. And in our research, we looked at sort of how systems change, and there were two kind of main drivers of change, and one was disruptive technology or events. The second was coordination. And I think that the push for sort of cross-sectoral alignment that is coming under COVID-19 is this disruptive shift. Now remember, during the crisis, there were many changes to payment of services and different state rules as well. But this provides an example of how if we really want to, we can make these changes. We can redefine coverage and redefine the terminology. Outside of that crisis, we need incentives for coordination. And I think that what we sort of concluded was coordination is very costly. It requires upfront investments of time and resources that are ultimately beneficial, but not captured by one actor, and therefore there is this notion of free riding, which Glenn is very familiar with and has talked about in his work. So the costs are borne by those who are pushing for coordination, not the network as a whole. And this is where things like T codes and a common language and a common sort of way of doing things, a template as such, is really, really important. So we believe that this is a mechanism for coordination, and the waivers have done this, but again, there's a lot of variation at the state level. So.
Excellent. Excellent. So I think that at this point, we're ready to kind of summarize a lot of our key findings and think about what it means for next steps. we're going to move on to the next slide. So what is the kind of takeaway in terms of what it is that we're finding with implications for integration? In essence, we need to create a common language across sectors. Aligning health and social services depends on clear conceptualization combined with real-world operationalization. We have to make sure that there's buy-in from both providers and payers. Using our multidisciplinary approach, we suggest that while some new systematic mechanisms are required to achieve alignment, others are currently hiding in plain sight. Current standards reflect and support two principal goods and services: products, where there's minimal kind of comprehensiveness, or professional services that are very narrowly defined. A set of de facto and de jure mechanisms have arisen that define billing and payment standards very narrowly. And this is where we really kind of focused our conversation today. To enhance this limited scope in pursuit of greater systems alignment, we recommend the adaptation of an existing terminology managed by CMS that could be standardized for public and private payers. In our prior presentation, we talked a little bit about MCOs and how they've also been part of the conversation in this regard. But first, blending these two systems require health to change beyond its current statutory definition, as well as for standards deeply rooted in federal and state regulation to evolve. Second, management systems should be supportive, allowing terminology and standards to transcend programmatic and public-private distinctions. And finally, adaptation of existing institutions to support the maintenance of this expanded terminology going forward is essential. There's empirical evidence that supports the technological change. There's empirical evidence, rather, of technological change bolstering our argument that standards created by government and representative institutions that support common standards are the best way to bring these two worlds together. We also have, I think, a number of findings that are relevant to the COVID pandemic, or they're kind of touched upon by Miriam just a moment ago, and those are something that we're going to elaborate on as we think about moving forward into next steps and new projects. Miriam, did you want to add anything to that conclusion?
I think just the need for and the motivation for coordination and greater consistency across the healthcare sector has been really highlighted by the COVID crisis. And we can use this as an opportunity to have new conversations about those opportunities.
Absolutely. So now we're going to take just a moment to talk about what needs to be done going forward to expand T-code utilization, and more specifically, how we overcome barriers. So I think that if you are following the argument that we've tried to construct, that T-codes are the answer in the kind of near future, then the next question becomes, why can't we kind of move forward very quickly? One of the barriers that kind of tends to come up, and we learned this after kind of numerous conversations with folks at CMS, is that kind of medical provider awareness of T-codes needs to be addressed. So as we touched upon, T-codes are developed to really address emergent needs at the time that those needs emerge. And then once that crisis is over, for example, some sort of natural disaster, then T-codes tend to just fall by the wayside. So the goal here is to elevate awareness about T-codes, keep them on the front lines, and make providers aware, as they are kind of in the habit of practicing, that they can actually provide some greater service beyond what they might have originally imagined when dealing with patients who are coming from certain backgrounds. This is also related to ongoing conversations about how providers are collecting information about social determinants of health in people's electronic health records. So again, kind of thinking about the extensions as it relates to the technological advancement is going to be critical. If you in fact find that a patient is coming from a significant distance and they may need help with transportation, or if you find that someone is coming from a family where there is some sort of substance use or abuse problem, how do you act upon that has been a common question when it comes to how we think about using expanded data that's being collected by providers about social determinants. And this is one way to really operationalize that information. So there is a way to actually prescribe and to assist patients once you collect that additional information. The flip side of that is thinking about non-medical providers who are also kind of critical in this conversation. They may not be aware that they have the option to be reimbursed through at least state Medicaid agencies at this point, and they will have to become kind of familiar with the processes that's required for them to be paid. There are some states that have done an extraordinary job of kind of reaching out to community health workers and other non-medical providers to make them aware of opportunities to assist. And so we have to continue to think about expanding that conversation. And finally, defining health through a social determinants lens. This is part of the work that I think we're all doing, to overcome this barrier. There are times where people would say, well, what do you mean by social determinants? And that would obviously be a kind of difficult question to answer when you're kind of deeply rooted in that framework. But understanding that even those who have been in health services and health systems for a long time don't quite understand what it means. So when we give them a very kind of tangible example like T codes, it tends to kind of create a good response. So related to that, the notion of awareness and knowledge, our initial strategy for moving forward is just dissemination of study findings in a way that really gets this language into the hands of folks who are decision makers. So pieces like op-eds tend to help raise the profile, not just for academics, but also for populations that are outside of the realm of systems research or health services research. Finally, before we get to our poll results, we want to talk a little bit about emerging related projects. And this is where we're hopeful that kind of the conversation that we have today will kind of continue to feed in and help develop these projects. But one of the key things that came up often and that has continued to be a point of focus in light of the COVID pandemic has been food insecurity. And it has really highlighted the need for policies that can increase access to SNAP benefits in a timely and efficient fashion. SNAP in some ways represents one of our most kind of flexible models for getting benefits into the hands of low income and other eligible vulnerable populations. And so policy surveillance and mapping is necessary to assess how states are using waivers during the COVID pandemic to increase access and reduce barriers to nutritious food, and in particular focusing on children who tend to be very vulnerable, especially if they are also eligible for things like school meals, school breakfast and school lunch, and their schools have been shut down due to the pandemic. So we've been engaged in kind of mapping projects that are designed to really understand the flexibility that states are using in this space and how that can be translated into larger conversation about services integration. And Miriam is also going to talk a little bit about food access in urban settings.
Yeah, we're developing a project which is centered on climate change around urban centers and the ability to sort of address climate change and food access in those settings. We're just at the early stages of that, but very excited about the direction of the work that's sort of following on from this project.
Excellent, thank you. And ultimately, what we're looking for is integration of federal social safety net policies and benefits. So the kind of big takeaway from this conversation has been that there really needs to be a streamlined approach to making sure that populations that have the kind of requirements or kind of meet the demographics for eligibility on a number of different federal programs can really access those in a much more efficient manner. And there's been some work on co-benefits, and we know that there are kind of emerging kind of studies on the ways in which states have tried to ease access and make it much more straightforward. And we're kind of leveraging a lot of that to think about creating a more integrated social safety net in general. So many populations end up falling through the cracks, if you will, because they simply are not able to harness all the different kind of help that's available to them because there is such high levels of fragmentation. And the level of state kind of variability when it comes to integration or administration rather can create significant barriers to accessing all benefits to which one may be available. So certainly we start here talking about T codes and talking about access to non-medical services using a medical model. So how do we get, Medicare and Medicaid to pay for non-medical services? Ultimately, we find that there's a lot of energy and interest around kind of taking a much broader perspective of what's shaping health outcomes in light of the COVID-19 pandemic, and thinking about how we can create greater access to all social safety net benefits in a more streamlined fashion. So I think we have just enough time, hopefully, to kind of go through our poll results. And I think that we're going to get some amazing technological assistance here that I'm impressed by that will allow us to see the results. Okay, fantastic. Thank you. I think that's Sedina who's making the magic happen. So it looks like the majority, 57%, felt like it had somewhat strengthened the likelihood of greater social and health services integration. So that's fantastic, because you said that before we got to this point, which means that hopefully you had found this kind of same kind of conversation in your circles. And then, so fantastic. So definitely, is what we're hoping for, is there's a window of opportunity. And then Miriam, for poll question number 2, did you want to take that one on?
I think this is very encouraging. If we can just have those results, yeah. Oh, so we've got 1 and 2. Okay, so are we talking about 1 or 2?
We're on question number 2 right now. Mm-hmm.
Okay. Because I had 2 and then 1. This is really encouraging, and I think that part of what happens in healthcare is getting the kind of trends and understanding where people are at, where the audience, where people working in healthcare, researchers, where they are and what they're thinking about, will help us sort of understand where things are going. So I appreciate you filling out the survey.
Excellent. And I realize I do see what you're talking about. It flipped, but yeah, the overall outlook was optimistic, I think, across questions. We have a final audience question. And from here, I think we're going to turn to the chat. And we'll actually share the results of this after today's presentation. But after today's talk, which word comes immediately to mind when you think about integration of social and health services? And whatever comes to mind is what we'll kind of be putting into our word cloud that we hope to share with you very shortly after this.
And you can direct that at the S4A team, or privately, or you can direct it publicly. It's up to you. But either way, we'll take your words and make them into the cloud. So.
Absolutely. So now I think is the moment where we're going to try to create as much space as possible to have a conversation, because this is what we wanted. We want this to be much more conversational. So I'm going to open up the Q&A, and I think that we're just going to get started. So we're going to, and I'm not sure if I'm supposed to read the questions, or Glenn or Miriam, or how we're supposed to do this.
You're going to ask the question.
Oh, okay.
Sure. I would be glad to moderate the questions. Thank you, Sarah and Miriam, for very interesting work you've toured us through today. So again, if you've got questions you'd like to ask our 2 panelists, please use the Q&A box down. Should be at the lower center of your screen if you're with us on the web today. Type your question and we'll try to get to it. So we've got a first question about the data systems that social service organizations tend to rely on and operate under tend to be very different from the health information systems that healthcare providers are using. So it's a question about whether there's a need to align data systems between social services and healthcare to try to facilitate this this alignment work that you're talking about. What can you say about alignment of data systems that might be helpful?
I can answer this question. So initially, one would think that's an insurmountable challenge. I think from the start, our attitude was, if you, and it's a cliche, but if you build it, they will come. And I think that there has to be an incentive there for people to change their systems, and if there's monetary incentive, the ability to receive reimbursement, there will be a gradual shift, not to underestimate the immediate short-term impact, and also not to, we need to consider the impact on those organizations. As you can see with individual physician providers, they have felt very stressed by the shift to EHR and the costs associated. So that would be the trade-off. But that's a great question.
Yeah, I agree with that 100%. And I would add to that, I think that we're seeing some examples of that kind of integration of existing data sets in light of the COVID pandemic. So for certain extensions of access to kind of food assistance, we see that the Department of Education in some states, which has information on students who are eligible for kind of free and reduced cost lunch, they are sharing their data about eligibility with state departments of health and human services who have information about households that are currently in a position whereby they would qualify for food assistance from a kind of federal perspective, right? So you have two state agencies, each holding different types of data, each having kind of different types of information, and they're kind of creating that interoperability in an effort to reduce the burden on individuals to be able to receive expanded access to kind of SNAP benefits. So we know that it can be done, it has been done, and the states obviously that kind of have been able to do this more easily are those where there's kind of much greater integration of there's much, I don't say integration, much greater communication between like the Department of Education and the Department of Health and Human Services, for example, or a Department of kind of, economic recovery at the state level. So we know that it can be done even with what exists now. I think the pandemic has shown that it takes a lot of energy, a lot of activation energy that I think Miriam is suggesting to kind of create that conversation in states where they typically don't have any type of interaction. So we can do it, states have done it. It just requires a lot of external pressure.
Fantastic. So we've got another question that asks about, recognizes that a lot of progress is being made around coding standardization through efforts that you all talked about, and but there's still some remaining problems about, first of all, how we incentivize providers to actually screen for social needs, and secondly, how we build payment mechanisms to support the social services delivery to meet those needs. So any thoughts you have about those two issues, how to incentivize screening and then how to pay for the social services, what kind of payment mechanisms to use?
Right, and this is a question asked by Edward in the chat box, but also touched on by many other attendees today. And I think that there's sort of a common theme across these questions in relation to questions about the Gravity Project and the United and AMA collaboration. And these are exciting collaborations. I think particularly the United Healthcare is leading their collaboration is very, very promising. The Gravity Project, from what I understand, is more, and my understanding right now is it's more targeted towards data integration, sort of the things that we were talking about before. I could be wrong, but that's certainly something that we need to add to our analysis for sure. So I appreciate you bringing that up. Some other questions also emerged along this theme of sort of integration and health information exchange with regard to the Z codes. And when we first started researching this, people were talking about Z codes, and these are ICD codes that are pretty recent for to address sort of social determinants of health-related issues. In our paper, we actually have a table with those measures, and that is absolutely critical for moving forward the debate. So, Sarah?
Yeah, I think that's accurate. I appreciate that coverage on the Gravity Project. I'll just maybe drill down on the notion about incentives to providers. So we touched on this a bit, and I think the way that we're conceptualizing that based on our key informant interviews for this particular study was the notion of what do providers do once they have the information. So it's kind of like providers are hesitant or reluctant to collect data that they don't feel has any kind of meaningful relation to how they're able to treat the patient. So if there's nothing that I can do when I find out, for example, that a patient of mine is in need of childcare services in order to kind of make their appointments, there's nothing I can, if there's nothing I can do, or if I think there's nothing I can do about the fact that they live in a community with kind of potentially high levels of lead in homes, I might think that, why am I collecting this information? So it's more so, how is this an actionable thing that I as a physician can address? Whereas if they were familiar with the fact that we have T codes that exist to cover kind of lead assessments of kind of levels of lead in certain homes, right? You might say, okay, I think that what might be happening here is that your child is being exposed to kind of lead paint, or there's some issue, some delay that's happening as a result of a particular environmental exposure. And in fact, I can help you cover the cost of giving some sort of insider knowledge through using the T code mechanism, right? T codes do pay for that if the state has a waiver in place that allows them to accept T codes. So I think the kind of key thing is, if I'm collecting information on the social needs, on the housing conditions, on the kind of transportation issues, on the kind of food insecurity issues of my patients, what do I do with that information? And we're suggesting that the incentive is that you can help the patient get the kind of finances or the kind of other kind of assistance they need to help diminish that particular risk factor. So you have an actionable result. And then I think hopefully that answers kind of part of question number 2, which is what is the mechanism to do something about that information once it's been collected? That was a great question. That's a really important question in this space. What do they do if they have information about social need?
Fantastic, thank you. So just scanning down our list of questions in the Q&A box. Another question, this comes up a lot in our conversations about health and social service alignment, which is really about, again, related to financing. Given that we know that we've got big problems with the current cost of the medical care system and how much we pay for services through the medical care system, how should we be thinking about how to, again, pay for this broader array of social services through the medical care system? Or should we be looking at ways of paying for these services outside of medical care financing strategies? How do we think about when should we pay for meeting for example, a housing need through medical care, and when should we pay for housing, an unmet housing need through other financing mechanisms, HUD, Section 8, et cetera? Any thoughts on that?
I think that certainly our intent is not to replace any of the existing programs that work really, really well. I think that, however, if we sort of continue to say we are going to bifurcate those systems, there's very little chance of those two coming together. And I don't think it's necessarily a question of social services integrating health, but providing the infrastructure so that health can integrate social services. We can't speak to the return on investment issue, and I know that's a very, very important issue. It falls outside our scope, but I think the argument that healthcare and medical care is expensive only accentuates the need for different approaches. So I'm confident that we can find money in existing budgets. I think that Sarah and I also believe that in terms of public support, I think there's a lot more support from American voters and members of the public to support health services. And partly it's a question of redefining some social services as also health services. So definitely our intent is not to duplicate that, but to provide a platform for expansion and greater political support.
Yeah, I agree. I think this is one of those things where we say, in some ways, trying to integrate social services into healthcare services is a daunting proposition. And oftentimes, I think we say like kind of the perfect becomes the enemy of the good is what we like to say when we're faced with this question, right? So it's like in a perfect world, we wouldn't have to kind of integrate social services into such a high cost setting. But does that mean that if there's some mechanism, for example, T codes and the kind of attendant regulatory changes that they will require, if there's some way to increase access at this time, should we kind of, delay that in exchange for creating a system that would kind of, in a perfect world or kind of in a more cost-efficient way or cost-effective way, address those social needs? And it's not clear, kind of the opportunity cost and what's lost in that kind of time frame. So it's not perfect. It's not a perfect integration, but it certainly is better for some than it would be if we didn't kind of move in that direction.
Fantastic. And if I could just take moderator's privilege to ask a quick follow-up. Have you thought much about the process of medical necessity determination, and as it's commonly used in both public and private health insurance programs, and whether we need to think about how that applies to these social services? Often, because that certainly could be one way of differentiating, again, when we should pay for housing assistance through the medical care system or through social services is whether a physician has made a determination that your unmet housing need is a medical necessity and therefore needs to be paid for as part of the package of services that's designed to address your. Any thoughts about how medical necessity determination processes may fit in here?
Yeah.
Can I jump in, Sarah?
Yeah, no, I'm thinking of one conversation we had in particular with a private payer. So you might remember this, but yeah.
I think we talked to many payers, and I think there is greater awareness of the need. I think there's one thing that the public health community that we've managed to do is get this conversation, all of us, push that debate forward among private payers who are taking note. I do think that there's some sort of services that may not sort of lend themselves quite to direct sort of funding and supervision through the health system. And I think Sarah and I had a lot of conversations about this in terms of housing not being, that would be something that would sort of have to be conceived slightly differently. But our idea is that physicians should be able to write a prescription. What we're thinking about is how do you move to the next step? And the Z codes are actually an important part of that medical necessity determination process. Getting payers together and getting some common agreement about these issues is a really important step.
Fantastic. Another question about health information exchanges. And we know that there's more and more projects that are underway across the country that are trying to integrate social service data and data from social service providers into HIEs. And I guess the question is, of any promising strategies in that arena that help to get social service data more available to medical providers?
Well, there could be more questions in terms of the electronic medical record when it's sort of set up, or doctors often ask has there been any changes in your medical condition. Maybe they could ask patients about their social determinants or the social determinants aspects of their lives to do that.
Yeah, I don't know of any specific organizations. I think there are demonstrations going on where there's greater medical providers are collecting more social services information or information about social needs, but not about the data itself.
And I might just give a quick commercial for that question. There are two related RWGS sponsored initiatives that are good sources of information about initiatives that are underway around integrating health and social services data. And they're related. There's the DASH program, the Data Across Sectors for Health, and then its affiliated initiative called the All-In Network. This is a network of, again, community-based projects that are all working on ways of integrating medical data with social services data and making that available kind of in, bi-directional mechanisms for both for medical providers as well as for social service providers. So and several of our S4A research projects have contributed examples into that, into DASH and All In. So you can check those out. There's a website for the development network and for the DASH program as well. Okay, I know we are getting down to our final couple of minutes. I guess let me ask one question I'll ask from the chat box here. Another challenge is that the time that it takes to get new codes defined and adopted into either the ICD diagnostic coding system or the procedure codes and T-code system. Any thoughts about how to accelerate that timeline or what we can do in the meantime while the work is underway to get new codes defined and integrated?
I think that the fact that the codes already exist, and we didn't really have time, one of the questions in the chat box was about which codes they cover, but there are a fairly comprehensive range. CMS does have a process for codes. It's actually a little bit more frequent than the other coding process, CPT. So obviously that's something that we'd need to consider, but I don't think that's an argument against it. I think it's something that we'd have to accelerate. It does take a long time for medical services, and that's why we should use some of the existing codes and build off of those.
Yeah. Just to follow up on that, I think the Alliance for HCPCS2 Coding Reform is a great resource to look into in relation to the conversations around transparency and the kind of process by which new codes are kind of introduced. They kind of have a wealth of information in that space, and it's very clear, I think, from some of those conversations and from some of the work that they put forward that it's not a process that they feel is very transparent. There might not be enough kind of accountability in the ways in which we think about which codes are adopted and which aren't. So I think that's almost a kind of a research question in and of itself, the kind of politics of kind of coding reform and adoption.
Fantastic. Well, I know our hour is coming to an end. And so, again, I want to thank our panelists for today, Miriam and Sarah and their colleagues at Columbia University for the great work that they're doing in this space. And thanks to all of our audience members for some very important questions. I know we didn't answer them all today, but we definitely encourage you to reach out to our investigators if you have follow-up questions or want to share more information. You can find contact information for this research team based at Columbia on the Systems for Action website, systemsforaction.org, where you can also find lots of information about our other S4A projects, research projects funded through this program. And of course, stay tuned for upcoming webinars. We do this Research in Progress webinar about every 2 weeks, twice a month. We've got some great webinars lined up for the month of June, including 2 of our newly funded S4A research projects that are just starting up this month. We're going to hear from several of these new projects over the next several sessions and what these new S4A system alignment studies are designed to do moving forward. So join us on June 10th and again June 24th to hear from 2 of our newly launched S4A projects starting up just this month. And again, thank you so much for joining us. Feel free to reach out to us at the National Program Office for Systems for Action if we can be helpful. Stay tuned to our website. Join our email list if you want to get up-to-date information on new funding opportunities and other research dissemination and translation activities that we organized throughout the year. Thank you so much again. Thank you to Miriam and Sarah for a great webinar. Look forward to staying in touch with you on this great work, and stay safe, everybody. Thanks so much.
Thank you.
Thank you. Bye.